Good evening, everyone, and welcome to tonight's webinar. My name is Tabatha Rando, and I thank you for joining us on this journey into rethinking exudate management. Albert Einstein is one of the most influential scientists who ever lived and had developed the theories of relativity and the basis of quantum physics, and is quoted as saying, "We cannot solve our problems with the same thinking we used when we created them." Now, you may be a novice in wound management or an expert, but keeping up to date with the latest evidence and best practice guidelines is essential. Take this patient, for example. Unusual wound location, unusual presentation with large exudate and slough in the wound bases. Take a step back and holistically assess the patient. We need to do this to identify the cause and contributing factors, the overall goal of wound care in partnership with the patient, and then address wound bed preparation via the wound bed preparation acronym TIME. These three steps are essential when managing wounds. Now, some of you have worked out by the distribution along the thoracic dermatome that the cause of these wounds were infected shingles. The patient was put on systemic acyclovir, treated with antibiotics. We used a thick layer of antimicrobial, anti-inflammatory hydrogel to cover and settle the infection inflammation and thus the exudate output. And with no sting peri-wound protection, we used to assist the protection of that skin. And also the use of silicone superabsorbent polymer, we were able to take up that exudate. We also looked at pharmacological and non-pharmacological interventions to support the wound's prompt healing. With nutritional supplementation, patient education, we got the result that we were after. Now, I love art and beautiful images, and to balance out all the other images we will view tonight, I've woven some of my favourite Van Gogh images in celebration of Van Gogh Alive exhibit, currently in Adelaide at the moment. Back to our discussions on exudate though, all wound management clinicians at times face challenges with wound exudate in the patients we care for. And we don't ever forget that he had a wound. Now, the exudate can be in the wrong place, in the wrong amount, or in the wrong consistency. And it's our patients who suffer when exudate is mismanaged. Wound exudate issues can lead to leakage, wound malodor, embarrassment, social isolation, increased bed linen and clothing laundering, and wound expansion as chronic wound fluid macerates the peri-wound skin. There's also an increased risk of infection with strike-through exudate, opening a porthole for microorganisms to track into the wound, and most importantly, increased pain. Have you ever stopped to think whether exudate mismanagement could be contributing to your patient's wound-related pain? It's a good question. Now, mismanagement of exudate can lead to chronic non-healing wounds, which cost not only the patient a lot, but the health system as a whole. Now, the financial burden of wounds, according to the health economics literature, is significant. Graves and Zeng in 2014 reported aged care and acute care costs, but did not include the GP and community wound rates in Australia. So this amount is likely much greater. And then we look at the US, where it's estimated between 28.1 and 96.8 billion US dollars per annum is spent on wounds. And the UK is also significant with 5.6 billion pounds. Now, the issues with the cost of wounds is part of our role as health professionals. We need to get our holistic assessment, holistic wound management, which includes wound bed preparation, correct. And management of wound exudate is a key part of that wound bed preparation. So we must aim to get exudate in the right amount, in the right place, in the right composition for healing, so we have happy patients. So during the next 40 minutes or so, we're going to be looking at these areas, looking at wound exudate and why it's important, the challenges around it, what are the best practice guidelines, and what are the latest evidence and advances in exudate management. So what are the best practice guidelines? This document, excellent document from the World Union of Wound Healing Societies, was published in 2019 and it's available for free download. So I encourage you to all have a look at this and gain some more information in this topic. Much of what I'm going to be presenting tonight is from these guidelines. Now, the word exudate is derived from exude or to ooze, from the Latin exudare, to ooze out like sweat. And those definitions that are in the literature and other informal terms for wound exudate, such as wound fluid or wound drainage, make sense to us as clinicians. In the acute or healing wound, exudate actually supports healing. It's not all bad and provides that moist wound environment that's necessary for wound healing. Exudate mainly consists of water with proteins, nutrients, electrolytes, inflammatory mediators, growth factors, protein lysis enzymes such as matrix metalloproteases and tissue inhibitors of matrix metalloproteases. These are usually in balance, and other waste products. It also contains cells such as platelets, neutrophils, and macrophages, and it's usually watery, clear to pale amber and odorless. Wound exudate is an important transport medium for cell nutrients, signalling molecules, and metabolic waste, and the movement of these across the wound bed is dependent upon a moist wound interface. Wound exudate is derived mainly from interstitial fluid found in the spaces between the cells and body tissue. An interstitial fluid is formed from blood in the capillaries and has similar components to blood plasma. Now, until recently, 90% of fluid was thought to have come back into the venous end of the capillaries and only 10% via the lymphatics. But recent research has revealed that the lymphatic system has a more prominent role in maintaining fluid circulation than previously understood. Mortimer and Roxon in 2014 identified that in most tissues and in normal circumstances, there is no reabsorption into capillaries. So it's a rewrite of Starling's 1896 hypothesis. So the interstitial fluid, about 8 litres per day, is taken up by the lymphatic system, where it becomes lymph and is returned eventually to the central circulatory system. Now, any factor that increases that amount of interstitial fluid held in the wound tissue will increase the amount of exudate output, and it depends on the pressures that are found in that network. So hydrostatic pressures, so any change in hydrostatic pressure, which is the pressure in the capillaries, will increase fluid out of the capillaries, such as venous hypertension. Onconic pressures, colloid protein pressures, and it's a pull, the protein actually pulls fluid. If there's less in the blood circulation, such as malnutrition or chronic kidney disease, it's going to be a lot more coming out of the capillaries. And then it's also the consideration of capillary wall permeability and their leakiness, and then more fluid might come out. And therefore we'll have more wound exudate produced. Exudate produced by a wound is dependent upon the wound healing phase, the wound size, depth and position, comorbidities, complications and other factors, as well as the wound etiology. Some wounds just have more or less exudate. And we can see here the high levels of exudate wounds, such as venous leg ulcers, dehisced surgical wounds, malignant fundating wounds, burns, inflammatory ulcers. Remember, inflammation and increased exudate output is linked. And also skin donor sites often pour out fluid. Then we have the wound types with low levels of exudate: ischemic arterial wounds, neuropathic diabetic foot ulcers, and dry stable eschar-based unstageable pressure injuries. So many factors can influence exudate production. The stage of wound healing. We have more exudate during inflammatory phase of wound healing and less during and towards the end of healing during epithelialization. General factors such as where the wound's located. If it's located on a lower limb or foot, it may produce more exudate, especially during the heat or humidity or hot weather. We have patient concordance, wearing their compression, for example. The wrong dressing or intervention being used can cause problems with exudate. Local factors that might increase exudate are wound infection, biofilm, foreign bodies, wound sinuses, fistulas, tumours, peri-wound edema. Also decreased exudate around those wound types of ischemia that don't have a lot of fluid getting to them, and an eschar-based wounds won't have that exudate. And then there's the systemic factors, which are super important. Someone might be having exacerbation of their heart failure or liver or kidney failure, and that just increases interstitial fluid, so therefore wound exudate usually increases. Endocrine disease, older age, obesity, liquefying adipose tissue causes a lot of exudate output. Infection, inflammation, malnutrition, decreased serum albumin levels. The lower it goes, the more exudate pours out. And we have other factors there, increased CRP, fluid overload. And then we have less exudate, the hypovolemic shock, dehydration, microangiopathies. So lots of different factors can influence how much exudate a wound produces. And that's why it's vital to look at the whole person before looking at the whole in the person and making sure we undertake that holistic assessment of the person, the wound, and their environment. And this wound, for example, was a wound that came into our clinic, and this lady allowed us to share her story for education purposes. Now, she had necrotizing fasciitis, multiple skin grafts, topical negative pressure, hyperbaric oxygen therapy, and 18 months later, her wound still had not healed on the back of this leg. Now, she came to our clinic, our multidisciplinary clinic, and we did a full assessment. We put her into best practice care, including some compression, nutritional supplementation, wound bed preparation, etc. We ticked all the boxes, and 2 to 4 weeks later, she still wasn't moving. She had had wound biopsies. There was no abnormal histopathology. And I just asked the question, what's her last bloods done? And when those blood tests came back, it was found that she had chronic myeloid leukemia undiagnosed, and her white blood cells weren't functioning and clearing that wound. So it's very, very important to have that holistic assessment. Why is wound exudate important? Paracelsus was the first doctor to actually write about wound exudate, and he called it nature's balsam. We move ahead to 1962, which was a historical year in wound management research, where the key functions of acute wound exudate were identified by Dr. George Winter, who was the British-born pioneer of the moist wound healing concept of modern moist wound management. Now, he took a pig and made superficial wounds. On one side of their wounds, he put a rudimentary polyurethane film, and on the other side, he left it to scab up and put a dry dressing on it. And what he found was that the moist wound environment had a faster epithelial migration, increased collagen production and angiogenesis, prompt autolysis, debridement, and it prevented the dry dressings from peeling off healing layers of epithelium. And it accelerated healing by 50%, and that's where we get our moist wound healing theory from. So in that healing wound, exudate is a good guy. It provides that moist wound environment, supports and supplies nutrients for cell metabolism, enables diffusion of immune mediators, growth factors, and tissue repairing cells to cross the wound bed, and also aids autolysis of necrotic or damaged tissue. So acute or healing wounds heal in a timely and orderly manner. And what does timely mean? 30% reduction of surface area over 4 weeks. Now, systematic reviews of different healing wound types, which undertaken and reviewed by the US Medicare system back in 2016, 2017, and they found that for all wounds, a 30% reduction in surface area within 4 weeks, no matter what comorbidities the person has in a healable wound, is the baseline for when they would fund and allow advanced therapies to start if the wound did not reach a 30% reduction in surface area within 4 weeks. So that timely gives us a bit of a ruler to measure our own wound advancing and towards healing. So that's timely. Orderly, we have the orchestral movement of healing with the number of growth factors, cells, and cytokines that are involved in those 4 major stages of healing by secondary intention. We have a hemostasis, hopefully occurs within the first 30 seconds to a minute or 2, depending on the medications that our patients are on. Then we'll have the inflammatory phase that starts in the first few days and or starts actually from the first day to day 4. And then we have the proliferative phase that moves forward from around day 3 to day 28, when our wounds should be healed within that 4 weeks period. And then from day 28 and again, the times are very flexible depending on whether people are fast healers or slower healers. The remodeling phase of wound healing is important for removing the emergency collagen and scar tissue that was elastin that was laid down quickly and re-strengthening it and making it a more orderly scar tissue. And that's when we see the scar colour change and come to that paler colour and well-healed scar there. But these chronic wounds that have very high levels of matrix metalloproteases 1, 2, and 9 are the ones that are stuck in the inflammatory phase of wound healing. And that's for many, many reasons, but in particular, not having a well-prepared wound bed. So in an acute healing wound, we have low to moderate exudate, nil odor, and often serous to hemiserous exudate. So what are the challenges around wound exudate? Let's have a look at those. Number one is the corrosive chronic wound exudate in the non-healing wound. And we know that it's corrosive. It has those proteases, the MMPs, that are actually meant to be in lower levels to help clear slough and other debris in the wound, but they're in super high levels, and there's low levels of their tissue inhibitors of the matrix metalloproteases. So a healing wound and a non-healing wound completely different from a molecular level. So those high inflammatory cytokines and protease activity, the low mitogenic activity of the cells, and those cells are just not dividing and helping with the healing. So that abnormal exudate composition, you can see in this photo here that the foam that was on that wound, that venous leg ulcer, was not managed by the foam. It wasn't taken up and it sat on the skin and literally, a bit like a chemical burn, it literally ate through the skin. So those higher inflammatory mediators and proteolytic enzymes are the bad guys. So you have less growth factors, you've got degradation of the extracellular matrix, the TIMPs and MMPs are out of balance. And when that protease activity in the wound is elevated, recent research has shown that there's a 90% chance the wound will not heal. So chronic wound exudate is a wounding agent in its own right, and we have to remove it. I want to talk a bit about maceration versus hyperhydration. Now, maceration is a softening and erosion of the skin due to prolonged exposure to moisture, proteolytic enzymes, and predisposes the skin to breakdown. Like we have with Arnie's skin on the left here. He's been dipped in a boiling mess of metal down there, and he's not looking good for wear. Versus myself, who's floating around a pool somewhere nice that we all dream that we could be on holiday in the middle of winter. I get a bit hyperhydrated when I sit in the pool too long and my hands go all that funny coloured white. And the definition around that is that prolonged exposure of skin to water resulting in swelling, absorption of corneocytes, which can be reversible. So when you get out your layer of your skin on your fingers that have gone white and wrinkly, doesn't actually fall off or die or anything like that. It's reversible. And this was picked up and published by Rippon, Uzi and Cutting in 2014 in the Journal of Wound Care, where they explain these two differences around maceration versus hyperhydration. And I've just identified an area of maceration, which is usually distal to the wound, whereas the hyperhydration from having too much water on that from dressings that area is actually reversible. So just be aware of those two different presentations of the peri-wound skin. Now, we need to avoid the chronic non-healing wound trajectory that's going the wrong way. And here we have these chronic wounds in a patient with mixed vessel disease in the lower limb, had malodorous high exudate peri-wound maceration. You can see the depth of the medial part of that wound. We addressed his nutritional issues. We followed the wound bed preparation model. We applied modified compression and regular debridement, peri-wound protection, and we actually used a superabsorbent dressing for these wounds, which have been present for over 12 months, but they promptly heal within 10 weeks. And you can see the difference between the swelling on the first visit versus us controlling that edema, that local edema. So looking at all these challenges, how can we manage wound exudate better? This is hot off the press. This is the latest wound bed preparation model from April 2021. And there's a bigger focus on identifying the goal of care and addressing the patient and family concerns. But what I find quite exciting is the focus. So we've got to identify and treat the cause and contributing factors of a wound, but the focus on identifying whether this wound has or the person has the ability to heal. And this is something that I think has been missing for a long time. I've been teaching it probably for about 20 years, that it's all good to identify and treat the causes and contributing factors in step one, but identifying the overall goal of care in partnership with the patient or family to give a realistic opinion of whether it will heal or not. And often if we don't think it will heal, we may even give it a trial of healing if that's what the patient or family or a significant next of kin would like. So that step two is quite important, identifying the goal. And then step three in this publication talks about DIME. Now this publication is from our colleagues on the North American continent in Canada. And I know they use DIMEs, but I think they do use DIMEs, but anyway, we don't. I don't think it's going to catch on that well, but I still talk about time with my colleagues at my workplace as well, because I know this is well established. But these authors in Mr. Gary Sivold talk about debridement as being so important that we need to change the first letter of the wound bed preparation time acronym. So just keep that in mind. I'll use time, DIME interchangeably. So this is how we're going to heal some of those chronic wounds. So we need to look at the whole person before looking at the whole in the person. If you can take away those three key steps and making sure you holistically assess the person, you will be better managing your exudate. There are also many other factors that impact on wound healing, which is not the focus of this talk tonight, but I point you to this excellent resource from Carolyn Dowsett from the UK on breaking the cycle of hard to heal wounds. So back to the wound bed preparation model: DIME or time, tissue debridement, infection inflammation, moisture balance, epithelial edge advancement, and surrounding skin. But we're going to focus on moisture balance. Now, it's interesting that every one of the other elements of the wound bed preparation model here on the screen all affect moisture balance. So getting those right, you will help control and improve your exudate management. So the removal of non-viable tissue and biofilm and foreign bodies. By doing that, you will reduce inflammation and the exudate will reduce. And debridement methods, however, many nurses, who I'm assuming are a main audience tonight, can do the first two: autolytic dressings and mechanical debridement. And open weave gauze is excellent, using a bit like an Enyo pad as a dry, again, making sure the person has had enough analgesia, etc., to with pain management. Very, very important before we debride, and obviously getting permission from the patient. I'm happy that they're on board and understand the reason why we're doing it. Is a great option if you don't have some of the amazing monofilament pads and other debridement pads that are coming onto the market now. But we all do have a plastic forceps, and when you break one of these open away over a bin, not flicking anything on anyone, you can use the serrations on the end of that to actually scrape away the sludge or the slough that is on a wound, as much as obviously you and the patient can manage. Now, with that, we really need to be mindful that cleaning off this dead tissue, vitalized tissue, slough, and probably evidence of biofilm is critical to kickstarting these wounds into healing. So we've got to reduce that slough and that non-viable tissue. Now we'll look at eye, inflammation, infection. By reducing infection biofilm and the causes of inflammation, our exudate will improve automatically. And I will point you towards some more documents for free for download. They're excellent resources. This is from the International Wound Infection Institute, the Principles of Best Practice from 2016. There's soon to be a new updated version available, but they point out that wound infection is the presence of microbes in sufficient numbers or virulence to cause a host response locally or systematically. Now, a wound infection is clinically diagnosed via signs and symptoms, and a MCNS swab is for antibiotic sensitivity. We don't use a swab to diagnose a wound infection. And the best practice document talks about local signs of infection, wound infection, versus systemic signs of wound infection. I'll let you read those, but they talk about classic versus subtle. And I've got a great photo there at the bottom of the page where I've got that epithelial bridging, trying to get across the hypergranulation tissue, not succeeding at all. The edges of the wound are standing up, very edematous. They're not happy. So you can see that it may not look like the top image, but those covert signs underneath are showing all support on a local infection there, a local covert infection. So watch out for those. Now, the spreading wound infection, that's when we use our antibiotics, our systemic antibiotics, and depending on how bad and how unwell the person is what their treatment that they get. But we don't want it to get to this. We want to catch it beforehand. And I wanted to also just bring in a device that I recently had the privilege of having a trial of. And I don't know whether anyone's seen this or if you used it in practice, but it's a UV fluorescent light emitter. So you darken the room, you turn the device on, and this fluorescent light, which activates porphyrins, which are the special molecules found in microorganisms, they actually glow a particular colour in the presence of this UV light at the power of 10 to the power of 4 or greater, the amount of or concentration of bacteria in the area. Now, this you might be getting so excited like I first thought, oh, that'd be great, but it's not a diagnostic tool. It's actually a clinical decision-making support tool for areas of debridement, and this might be what the future looks like. But here's a couple of photos before and after debridement, so seeing how important removing devitalized tissue is. The colours here, I'll get my little mouse here. This is Staph aureus. It glows a red, and you can see the Staph aureus build up in 10 to the power 4 in the other areas around the wound. After really good clean wound bed hygiene there, and we're sharp debrided that big chunk of dead tissue out of here, it's looking much, much better. We then have a look at the dressing itself and how much bacteria is sitting on the dressings there. So yeah, just a very interesting experience. Now, the presence of biofilms in chronic wounds adds to wound exudate issues and incident of repeat infections. And I want to acknowledge Dr. Matthew Malone, who has shared these images with me. And we can see here Staph aureus cocci here with the extra polymeric substance that it creates. These bugs create this substance around them, a protective coating, which stops antibiotics from getting in and actually doing what antibiotics do best. Now, the definition of a biofilm is a structured community of microbes that have genetic diversity and variable gene expression that create behaviours and defences that are used to produce unique infections that is characterised by significant tolerance to antibiotics and biocides. And this, the presence of a biofilm, and because you may think, well, what is it and why is it important? It's basically a bug supercity that keeps the wound being in this chronic inflammatory process. And if you're thinking, well, has my patient got this? These criteria, if you've got a patient that's going on and off or cycling through every 4, 6, 8 weeks antibiotics, so the antibiotics are failing, your topical antimicrobials are not doing the job, there's delayed healing on antibiotic cessation despite best practice, we have increased exudate and moisture because the body's trying to clean this off. There's low level of chronic inflammation, erythema, and poor granulation or hypergranulation tissue. And an example here, we're seeing the effects of biofilm in a stalled wound. This is an 8-week-old donor site that's failing to heal. And although the microbiologists say we cannot see biofilm with the naked eye, there is some move to around or thought around that this sludge-looking gel on the surface of this wound is actually the evidence of biofilm. It's the effects of what the biofilm does to the wound. So in more best practice statements, and there's also another one called the Wound Hygiene concept, which I encourage you to look at as well. But this changed my life when this came out in 2017. Cleansing, debriding, antimicrobial soaking, and then using antimicrobial dressings 3 times a week for 2 weeks. And why is it 3 times a week? Because a biofilm will reform. It starts to reform within 24 hours, and it reaches its peak again around the 72 hours. So doing that regime can actually kickstart these wounds incredibly. So I've talked about T, I, and now I'm going to talk about M, moisture balance. Exudate is a key sign of the health of a wound. And you can see here that this isn't looking healthy, and when we take down the dressing, there's problems. So exudate's your key warning sign. And the problems of excess exudate we've touched on before, but the protein loss and the fluid and electrolyte imbalance is something that we really need to be mindful of and know to replace, because it's going to compound the issues with exudate continuing to leak out of these wounds. So exudate management requires a comprehensive and individualised plan that takes all these elements into consideration. Now, each of these elements should be part of your patient's wound exudate plan. We need to also consider that the patients and carers may be their own wound experts, sometimes having dealt with their own wounds for years. And it's amazing that just taking a few minutes to listen to what has worked and what has not previously worked, and to simply acknowledge that they are their own wound expert is incredible for the therapeutic relationship between the health professional and the patient or carer. And also key is managing wound bed moisture. It needs to be appropriate for the overall treatment of goal. That's step 2. What's the overall goal of care? Is it a healable, or is it a maintenance wound, or is it a palliating wound? Now, for example, a dry eschar-based wound in a lower limb with unknown arterial supply should be maintained and not rehydrated, as if there's not enough arterial blood supply, moisture in this setting can quickly lead to wet gangrene, for example. So the assessment of exudate must occur as part of that structured, holistic wound assessment, looking at the overall health of the patient, the current wound management practices, who's doing what, address the patient and carer's concerns, care for that peri-wound surrounding skin and condition and protect it. We need to look at the wound bed and the TIME acronym, which I'm going through now, and also the exudate assessment, the type, the amount, and the odour, and also protect against further wound development risks. So our exudate management should aim to support the wound bed moisture levels as per the patient-centred goal, provide that peri-wound skin protection, and manage symptoms to improve quality of life, which is what it's all about. So peri-wound protection is essential. Use those skin protection wipes and no sting ones that come in sprays, wipes, creams, lollipops. You can also use hydrocolloid winding and ensure the appropriate use of primary and secondary dressings. So moist interface, we need to know what is in our cupboard and how to use it wisely. And we don't want the wound bed too wet, like a soaky wet rainforest, or too dry, like a desert or desiccated wound bed, because the cells won't grow. And always, always, always assess the dressing that's removed, the type, the odour, the amount, the leakage points, the frequency of change, and the ease of removal. Also watch out for the shower soaker. Waterproofing and ADLs are very, very important, and iatrogenic maceration is an issue. It's when the dressings get waterlogged when they're in the shower because the Glad wrap and the garbage bags have leaked, no matter what people do. And I had a lady this week actually thank me for pointing in the direction of what you see on the image there, which is called a limbo, L-I-M-B-O. If you're not aware of it, look it up. It'll change your patient's life with lower limb wounds generally. And it has this wetsuit material at the top of it that seals the leg and stops water from getting in. So look at carefully if things aren't adding up. Edema control is also a key element in moisture balance. We've got to control the edema with compression and exercise, get that fluid back where it belongs. Assessing exudate type, amount, and odor, the good, the bad, and the ugly. Here we have the good, the serous exudate. Then we have the bad, the seropurulent. And then we have the thicker bad, the purulent. You can see here we've got Pseudomonas in the colour of that, and you can see the foam dressing hasn't taken up that thick exudate. And then we have the purulent, that cloudy, thicker, creamy one. It's the evidence of infection, contains pyogenic organisms and other inflammatory cells. Another ugly may be a little or no exudate, and it may indicate a systemic problem such as, in this case, calciphylaxis. That normal calcium accumulation in small blood vessels of the fat and skin. These wounds are usually extremely painful and cause serious infections that can cause all sorts of problems. And then another ugly presentation is little or no exudate, where someone has tried to rehydrate eschar in a limb that didn't have any or very much arterial blood supply. So that lower limb necrosis, you put a hydrogel on that, it's going to be wet gangrene quickly. And this is why vascular surgeons often do not like hydrogels, because they're misused in their patient cohort. So know your exudate. So here's a bit more information for you around the different exudate types. But just think about serous exudate. If it's starting to increase, it might be early signs of bioburden. Also, if it increases quite quickly, you might have heart failure, an episode of, congestive cardiac failure there, or venous hypertension might not be controlled, malnutrition, or we might have a lymphocele, so an entry into a lymphatic vessel. Then we have the hemoserous, pinkish because of the red blood cells, the sanguinous, it's reddish because of more red blood cells. Then we have the more of the uglier type, the seropurulent. It's cloudier, creamy, but still a bit, it's not as thick as the purulent. And then we have the hemopurulent, which is blood and pus, which is very inflammatory and a significant infection there. Then we have new types, and I've popped the word rethink here with looking at these two particular types, which I haven't really used in my practice before, but are important as they're doing more research on what actually is slough and what is contained in certain different exudate types. So fibrinous is that cloudy exudate. It can be thin and watery, and it's cloudy because of the fibrin strands that are coming off devitalized tissue there, and it's also indicative of inflammation with or without the presence of infection, and hemorrhagic, which is what I would call bloody exudate, but the proper name is hemorrhagic exudate. And again, usually trauma, there's some sort of inflammation trauma that's causing that blood to be basically our exudate. And then we have the wound exudate amount, which is very subjective. The best practice guidelines for wound exudate talk and lean towards Falanger's wound exudate score, but I have concerns about it because the wound exudate score 1 and 3 talk about dressings, but score 2 doesn't. And that is open to interpretation. Then we have the exudate amount, which a lot of different organisations utilise. We also have wound moisture levels and dressing exudate interactions. We've got other descriptive terms there that more or less are like the previous one. And then we have wonderful Professor Carolyn Carville from Curtin University in Silverchain in Western Australia, who I like to keep it simple. Nil, low, moderate, and heavy, and what the exudate is actually doing to the dressing. Clinicians are able to remember this a lot better. And obviously, we're trying to avoid that strike through in that heavy dressing saturation and leakage, because that strike through is a porthole for infection. Now, wound exudate odour is, again, another subjective area, and Horton and Young was the first group that looked to try and quantify this for research. The most validated tool for wound exudate odour is the Tala indicator for assessing wound odour, and it talks about distances from the patient and whether the dressing's down or not. Another score is from Nix in 2016, which is the absent, faint, moderate, strong. Again, very subjective. What I use in my practice is no odour, some odour, malodour, again, because it's keeping it simple, sweetie. Now, wound exudate and managing odour, why is there odour? You've got to ask the question. So there's usually a microbial load or necrotic tissue or malignancy and dressing leakage. If you contain exudate and seal it, you will not have odour. So it's much like the use of stoma appliances with a stoma. If it's sealed, you're generally not going to get the odour. Now, cleansing soaks, such as superoxidized solutions, PHMB, octenolin, if it's heavily contaminated, you could be using povidone, iodine, or chlorhexidine, which the Joanna Briggs Institute have done in their reviews is appropriate in the heavily contaminated wounds. But those first three are types that will be kind to fibroblasts and other human cells and will really support healing. Dressing suitable that contain charcoal, which is odour absorbing, and all your antimicrobials will help with reduce odour, and you've got to stop that leakage. Other environmental strategies are odour neutralisers, essential oils, deodorants, good ventilation, and disposing of the dressings outside straight away. Kitty litter under a bed, and even putting together tea bags, a pad of just your black and gold, no name, basic tea bags. Lay 9 of them out, connect them with a bit of Hyperfix each side, and put that on your outside your secondary dressing, and it will help absorb odour. This was a tip that Professor Carolyn Carville has shared previously, and it came out of the tannins in the tea actually absorb the odour, and it came out of some Vietnamese nurses that had shared that information. So we need to know what is right and what is not. And what are the latest advances in wound exudate management? We need to understand what the dressings do and what they do to moisture. Do they donate or absorb, or do they do both? And getting moisture balance right is important. If it's a dry wound, you usually add moisture, and we're trying to heal it if healing is the goal. If it's a wet wound, we usually try and absorb the moisture. The exceptions, though, are dependent upon that holistic assessment and identifying the overall goal of wound management. We can see here by the colour of that leg in the top image that it's very pale, and we've got peripheral arterial disease. If we rehydrate that, we'll have wet gangrenes. We don't want to do that. And in the image below, we have candida infection from a Philadelphia soft Philly collar. And if you put moisture on that as well, it's going to flare up. So you need to treat the local candida infection first. So thinking about composite dressings are also important, that we probably need to rethink as far as unique capabilities. And I'll share a bit more about that as we go. And I had a bit of a rethink on that moisture wound dressing function and getting the moisture balance. Now, when foams first come out on the market, and I'm old enough to remember this in the 90s, late 90s, that, well, actually early to mid 90s, that the foams were marketed around use in heavily exuding wounds. But in reality, low to moderately exuding wounds is often where they sit, and they do not manage thicker consistency of exudate in general. There's one foam on the market that does, but most of them do not. So I've put together this little progressive step-by-step where on the left-hand side at the top there, we're hydrating the wound, and we're moving towards that minimal to moderate exudate. As we move forward, that low to moderate exudate amount where foams are position foams, and then the heavily exuding wounds where you've got your silicon superabsorbent polymer dressings, you've got your gelling fibres and your alginates, plus or minus antimicrobial agents, and the potential wear time of these dressings. And then over in the bottom right-hand corner, don't ever forget our topical negative pressure wound therapy, and there's many of them on the market now.
So here's an example of moving towards hydrating a wound. And this case was an 86-year-old who had dementia, double incontinence, heart failure, polypharmacy, spilt hot cup of tea on the thighs. And we started the hydro-responsive dressing and film on the left there in 20th of February. Around this, just late March, early April, we started using the AquaClear gel foam composite dressing, and this particular dressing helps concentrate epidermal growth factors at the wound bed dressing interface. Its unique ability to do that, and with research to back it, is amazing how quickly it helps with epithelialization. So there's an example of hydrating the wound in those healable and no to low exuding wounds. And also looking at the hydro-responsive wound dressings being 2.5 times more efficient compared to intrasite gel as clean site study groups that were published. Now, composite dressings, this use of the foam with the AquaClear gel technology. Here we have a mixed vessel disease lower leg ulcer in the Agata region, and within 6 weeks, nice and clean, we had it healed. Then we have the heavily exuding wounds, the composite use of the composite dressing with silicone. And these are for they're super absorbents, these polymers that are inside this dressing. And you can put down other primary dressings if you need to, depending on what you want done with the wound bed, but they also work very well alone, depending if you've got a clean base. So they're for your heavily exuding wounds. Now, these silicon superabsorbent particles, being relatively new to the market in Australia, are able to cope with varying exudate levels, low up to heavy. And this particular article that was published last year has facilitated effective patient self-care, especially in the group of COVID, where we've got COVID isolation happening. So self-care, patient self-care is really a big new focus. And then we have topical negative pressure wound therapy to manage very large amounts of exudate and prevent contamination. And it works by providing a negative pressure, usually a foam or a gauze into the wound base, popping a film dressing over the top, and then connecting a port and tubing to a pump that will apply that negative pressure to the wound bed, usually around the 120 millimeters of mercury negative pressure, to help grow those new cells in the wound base promptly and removing that exudate and that local edema. And it's done through micro and macro tensions on the cells to actually really promptly help with granulation tissue formation and wound contraction. But we do have contradictions for topical negative pressure. Those necrotic tissues with ESCA, you've got to have generally 30% or less slough in a wound bed, or necrotic tissue in a wound bed to be of use. Do not use it in people that are high risk of bleeding, those unexplored fistulas, osteomyelitis that's not being treated. Got to be very careful with exposed blood vessels, nerves, etc. You should put an interface down with those, and it's usually surgeon driven. And malignant wounds, unless they're palliatives, that we're doing it for comfort. And wound drainage devices for heavy exudate are also used in wounds that are palliating, fungating tumours, etc., where topical negative pressure isn't available, those fistulas, sinuses, and to contain odour, and when there's no other option. Be friends with your stomal therapist. They will help you greatly in these heavily exuding wounds. So to conclude, in a healable wound bed moisture levels need to be a Goldilocks moment. They need to be not too wet, not too dry, but just right. And in these healable wounds, we need to decrease infection and remove biofilm and necrosis. We need to prevent pooling of exudate. We need to facilitate that moist wound interface, and we must remove corrosive wound, chronic wound fluid to decrease that inflammation. Now, I love this quote by Einstein. Education is not the learning of facts, but the training of the mind to think. And that's why we attend such educational events that Hartman have put on tonight, and I thank Hartman for the opportunity. And it's to challenge the way we think and the care we provide to patients. And this is all for the sake of improving the outcomes of the wounded we care for. And there's nothing more satisfying than having someone's wound heal. Thank you, everyone.